Endodontic emergencies. Endodontics is a specialty of dentistry which is often the front line for emergency dental care. These emergencies can include difficult diagnoses in addition to pain and swelling from infections and/or trauma. It is an emergency if the patient thinks it's an emergency. Pain and swelling, or both, from an endodontic emergency can have its origin from dental pulp disease. This inflammation is a progressive disease which has its origin in the bacterial invasion of the dental tissues. An orderly approach to the clinical management of endodontic emergencies begins with testing for clinical and radiographic findings. This progresses to a differential diagnosis with the ultimate goal, a diagnosis and treatment plan. It is helpful to review the anatomy of the head and neck region. The first priority in the management of dental emergencies is the goal to resolve acute symptoms and relieve pain and infection. Endodontic emergencies may present with many different appearances. A dental emergency is not planned or welcome. It is an inconvenient and uncomfortable disruption to the life of your patient. Dr. Grossman is a founding icon of endodontics. His words remain true. Patients will judge your care by how promptly you see them when they are in pain, and your skill by how quickly you relieve that pain. The initiation of white spots formed in enamel is initially reversible. However, if this defect of dental hard tissue enamel continues to progress, it becomes irreversible with bacterial invasion into dentin and reaches the cavitation stage of dental decay. There is a reaction in the dental pulp even before the bacteria have reached the pulp. The symptoms as bacteria come closer and closer to the pulp have a range of severity. The initial symptoms are typically milder and can be reversed. This is considered reversible pulpitis, where the pulp is still capable of recovery. Further progression of bacteria reach a condition where the pulp cannot recover and is termed irreversible pulpitis. This is often found with lingering and spontaneous clinical symptoms. This is a cell-by-cell progression. Damage to the pulp occurs long before the periodontal tissues are reached. The spreading out of inflammation and infection from the pulp and root canals into the periapical tissue result in a periapical abscess and cellulitis of the periodontal tissue. This is a cell-by-cell progression. Damage to the pulp occurs long before the periodontal tissues are reached. The spreading out of inflammation and infection from the pulp chamber and root canals into the periapical tissue result in a periapical abscess and cellulitis of the periodontal tissue. Dental emergencies are actually quite common. Each visit to the emergency room caused by a dental infection costs about $1,000. These dental pain emergencies result in large number of days missing from work, and a third are from endodontic causes. Far and away, dental emergencies have pain, and the origin of this pain is pulpal or periapical. In 1996, American students missed over 1.6 million school days for acute dental reasons. The many factors in the definition of pain include noxious stimuli, which are modified by the influence of past experiences of cognitive, emotional, and motivational history. Each patient brings their own unique response to pain. Dr. Cy Olliott described dental pain with many possible factors to be considered. There is a localized dental origin from the pulp and periapical tissues. Other possibilities are sinusitis, periodontal or other dental disorders and parafunctions, psychological and neurological, or even systemic origins of pain. There are several components to consider with regard to endodontic pain. There is the perception of pain and the reaction to pain. The perception of pain is influenced by anesthetic. The reaction to pain is influenced by many complex and overlapping factors. The emotional state of the patient is also a varying component. The pain fibers in the pulp include A beta fibers, whose role is not yet clear, A delta fibers, which are myelinated, have a low threshold for firing, and are fast-conducting fibers. C fibers are unmyelinated and have a higher threshold. They are slow-conducting. The noxious stimuli is a signal to the nerve, which signals to the spinal cord and brain. This produces the perception of pain. Pain causes the release of inflammatory mediators. In 1986, Brandstrom proposed the hydrodynamic theory of dental sensitivity. He explained that the movement of fluid in the dental tubules results in the activation of the small myelinated A-delta nerve fibers. This results in the perception of pain. The progression of injury and resulting inflammation lead to the activation of unmyelinated C fibers. In 1986, Brandstrom proposed the hydrodynamic theory of dental sensitivity. He explained that the movement of fluid in the dental tubules results in the activation of the small myelinated A-delta nerve fibers. This results in the perception of pain. The progression of injury and resulting inflammation lead to the activation of unmyelinated C fibers. Management of endodontic emergencies is first focused on capturing the patient's chief complaint in their own words. Word-for-word capture concisely what brings the patient in for emergency dental care. Management of endodontic emergencies is first focused on capturing the patient's chief complaint in their own words. Word-for-word capture concisely what brings the patient in for emergency dental care. There are key factors to focus on capturing. Record where the pain is located. Have the patient describe this as accurately as possible. They can point to the area or region. Is it pinpointed or radiating? How long has the pain been present? Is this the first episode, or have there been previous episodes? This helps to determine acute or chronic. The character of the pain is also important to capture. Is it sharp and stabbing, or dull and diffuse? What provokes the pain? The initiating factor can give you clues as how to reproduce the pain. This may be the only way to locate the source of the pain. What relieves this pain? Does it go away on its own, spontaneously, or does it linger and need analgesic to relieve the pain? Is there redness, swelling, or tenderness in the area? Dental history is pertinent. Recent restorations, history of mouth guard, clenching, grinding, bruxing, periodontal treatment, or trauma are also critical information to gather. The patient will often give you the critical information which is needed to make a diagnosis. If a diagnosis cannot be made, then treatment must be delayed until it is clear what is needed. The description of pain is often quite helpful in determining the source of non-odontogenic toothache. Let the patient describe the quality of pain. Their words will be a great source of information. If there is not an obvious pulpal or periapical source for pain, it is a red flag to consider a non-odontogenic source of pain. Often, such pain will be spontaneous, vague, and radiating. Constant and non-varying pain may be non-odontogenic in origin. Neurologic pain may have qualities of shocking, burning, or pricking sensation. There are unfortunate cases where inadequate diagnosis and treatment planning have resulted in the mishap of numerous endodontic procedures. Endodontic emergencies can be grouped into categories according to the timing of their occurrence during treatment. An emergency can occur before, during, and after treatment has been completed. Endodontic emergencies can be grouped into categories according to the timing of their occurrence during treatment. An emergency can occur before treatment, during the course of treatment, and after treatment has been completed. The website of the American Association of Endodontists has a glossary of endodontic terms. This is a useful resource for the current terminology. It is used for pulpal and periapical diagnosis. These are the terms which you will use in endodontic clinic. As mentioned earlier, the pulpitis categories range from reversible pulpitis to symptomatic irreversible pulpitis and necrosis. The periapical diagnosis includes asymptomatic apical periodontitis, symptomatic apical periodontitis, acute apical abscess, and chronic apical abscess. These pulpal and periapical definitions are found in the AAE website Glossary of Endodontic Terminology. The pulpal and periapical diagnosis will be formed from your clinical and radiographic findings in clinic. In vital teeth, the category of reversible pulpitis is a clinical diagnosis based upon subjective and objective findings indicating that the pulp is capable of healing. This pain often ceases when the stimulus is removed. Some causative factors include caries, exposed dentin, recent dental treatment, and defective restorations. Reversible pulpitis can be treated by removing the cause, sealing the exposed dentin, and a bacteriotight seal with a coronal restoration. Measures such as Vitribond, Limelight, or calcium hydroxide base may be indicated. Sedatives, dressings, and linings, also mineral trioxide aggregate, may be used. Bogan studied 40 patients with reversible pulpitis. With a 2-visit protocol, caries were removed, sodium hypochlorite used for hemostasis, MTA placed over exposures, and the teeth restored provisionally. At recall visits, patients were evaluated for reparative dentin formation, pulp calcification, continued normal root development, and evidence of pathosis. He found that MTA is a reliable pulp capping material on direct carious exposures in permanent teeth. Further information with vital teeth is the characteristic of pain in reversible pulpitis. This pain is of very short duration and doesn't linger after the stimulus has been removed. It can be described as sharp, piercing, lancinating, and it is usually localized. The tooth is not sensitive to percussion. There may be an exaggerated response to vitality test, usually cold but sometimes heat. The radiographs have a normal appearance. There is no apparent widening of the periodontal ligament. The case of irreversible pulpitis in a vital tooth is a clinical diagnosis based on subjective and objective findings which indicate that the vital pulp is inflamed and incapable of healing. Other findings with symptomatic irreversible pulpitis are the pulp is inflamed to the point that it cannot heal itself. In pulp testing, you may find an exaggerated response, such as lingering after cold. Causes for this are caries, recent dental treatment, trauma. As the carious lesion encroaches on the pulp, this pulp becomes severely inflamed and causes acute pain due to the confined space. The following are properties of pain in acute irreversible pulpitis. Pain may radiate initially, but once the PDL has become involved, the patient will be able to locate the tooth. The tooth then becomes tender to percussion once infection has reached the periodontal ligament. A widened periodontal ligament space may be seen on the radiographs in the later stages. With the differential diagnosis of reversible versus irreversible pulpitis, the following features are to be considered. Characteristic features for irreversible pulpitis are spontaneous pain, pain persisting after the stimulus, lingering, pain triggered by heat, pain is worse at night, pain at night, longer history of pain. The cold test can be performed with the endo ice or CO2 snow stick. A positive response is expected with a vital healthy pulp. Abnormal responses, such as sharp or painful responses or lingering responses, can occur. Methods for cold test. The CO2 snow stick is sprayed into a tube and condensed. It's more fragile and a little more technique sensitive to use. Refrigerant spray, endo ice, is sprayed onto a cotton fiber or cotton pellet and applied individually to teeth being tested. It has been shown that both CO2 and refrigerant spray produced equivalent responses, but refrigerant spray produced a faster response. The electronic pulp test can be used to assess the pulp's neural response. It can be placed on exposed dentin and used as a stimulus to gather information on the pulp's ability to respond. There can be false positives and false negatives with this test. Toothpaste is used to conduct the stimulus to the dentin. The heat test is useful to stimulate the predominantly slower C pulpal fibers. It is essential for diagnosis by exclusion technique. The pulp can be abnormal but vital, or the pulp can be necrotic. A painful response to heat is usually severe and may be delayed. This is when the pain may be more difficult to localize. It can be diffuse and sometimes referred. Application of heat is technique sensitive. A warm gutta-percha stick can be applied to the teeth being tested. Please put Vaseline or lubricating agent to prevent the warm gutta-percha from sticking to the teeth. Also, warm water can be used to apply heat, and the rubber dam can isolate the teeth being tested. It is a challenge to localize the correct tooth. If the pulp infection has not spread to the periodontal ligament, pain radiates, and the patient is not always able to localize the source of the symptoms correctly. Careful thermal pulp testing of all teeth, especially the application of heat, may be helpful. After that, it is possible anesthetic tests might be needed. It is a challenge to localize the correct tooth. If the pulp infection has not spread to the periodontal ligament, the pain radiates, and the patient is not always able to localize the source of the symptoms correctly. Careful thermal pulp testing of all teeth may be helpful, especially the application of heat. Anesthetic tests may also be helpful. Next is the diagnosis and management of orofacial pain. Anesthetic may be used to further localize pain. It may be applied to the periodontal ligament to pinpoint which tooth, or as a ruling out from the opposing arch. Symptomatic irreversible pulpitis may be difficult to localize. The acute onset pain may refer to different areas. It can be difficult to localize the source of pain to a single tooth without diagnostic testing. The pain may radiate to the temporal region from the mandibular molars, maxillary premolars, mandibular premolars. Pain can radiate to the ear from mandibular molars, maxillary molars. Sometimes mandibular molars and the heart can radiate pain to the neck and shoulder. The late stage of pulpitis, as the continued inflammation moves toward the apical tissue, the causative agent escapes the canal and is easier to localize the tooth. There can be challenges with the treatment of a dental emergency due to difficulty with local anesthesia. As the tissue pH falls during inflammation and infection, local anesthesia is not as effective. A higher volume of anesthetic may be necessary. Additional anesthesia techniques, such as long buccal, lingual, and palatal, may be required. Intraligamentary or intraosseous injection are also helpful. Intrapulpal anesthesia is helpful. It's very brief, not lasting long, but it sometimes provides a supplemental technique. Inhalation sedation, such as nitrous oxide with local anesthesia, can also give pain relief. Symptomatic apical periodontitis is an inflammation of the apical periodontium. Clinical symptoms include a painful response to biting and percussion. It may or may not be associated with an apical radiolucent area. Symptomatic apical periodontitis versus acute apical abscess. In the early stages, the difference between the two is not always clear. Radiographic changes range from initially a widening of the periodontal ligament space to later a well-defined area. An acute apical abscess is an inflammatory reaction to pulpal infection and necrosis. It is characterized by rapid onset, spontaneous pain, tenderness of the tooth to pressure and palpation, pus formation and swelling of associated tissues. Fascial spaces can become involved with dental infections, primary when it is a space directly adjacent to the origin of the odontogenic infection. Secondary is when a space that becomes involved following the spread to primary spaces. Areas which are fascial spaces connecting from regions of the face are as follows. From the mandible and below, connecting into buccal vestibule, body of the mandible, mental space, submental, sublingual, and submandibular. The cheek and the lateral face can connect with buccal vestibule of the maxilla, buccal space, submasseteric, and temporal spaces. The pharyngeal and cervical areas can connect with the pterygomandibular, parapharyngeal, and cervical areas. The midface can drain from the palate, base of the upper lip, canine and infraorbital areas, and periorbital. These are potential spaces into which infection can spread. Infection from mandibular posterior teeth can drain deep to the buccinator muscle into the buccal vestibule of the mandible. This is superior to the mylohyoid muscle and superior to the platysma. The mental space becomes infected when mandibular anterior teeth drain infection deep to the mentalis muscle and superior to the platysma muscle. Infection reaches the submental space when infection drains from the mandibular anterior teeth inferiorly and above the platysma muscle. This is deep to the mentalis muscle. The lingual space becomes infected when drainage leaves the mandibular posterior teeth lingually toward the midline and above the mylohyoid muscle. Beneath that is also the platysma muscle. Submandibular space involvement occurs when mandibular posterior teeth drain infection inferiorly and inferior to the mylohyoid muscle. This is bounded inferiorly by the platysma muscle. The parapharyngeal spaces are the potential spaces deep to the parotid gland and medial pterygoid muscle and posterior to the superior constrictor muscle. The midface area includes drainage from the periorbital space and the orbicularis oculi muscle and canine space. Tronstad studied in 2003 how do we treat symptomatic pulpitis. 92% of the time for a pulp exposure, a medicament and a bacteriotype seal were placed. In pulpotomy and medicament in the pulp chamber and bacteriotype medicament 98% of the time. With pulp extirpation and medicament in the root canal and bacteriotype seal 91% of the time. And with complete debridement and intracanal dressing and bacteriotype seal 99% of the time. A study by Oguntabi in 1992 found how we treat irreversible pulpitis using 3 different treatment regimens for irreversible pulpitis in 1,763 patients. The incidence of postoperative pain in molar teeth was the greatest with partial pulpectomy, 13%, second with pulpotomy, 8%, with complete pulpectomy, 6%. That was most effective. The 2003-2004 American Academy of Pediatric Dentistry guidelines included pulpotomy procedure in primary and young permanent teeth was the amputation of the affected or coronal portion of the dental pulp, which preserved the vitality and function of all or part of the remaining radicular pulp. SEC reported that pulp capping and partial pulpotomy with calcium hydroxide on traumatically exposed permanent pulps are successful 96% of the time. A study by Hasselgren in 1989 of 73 patients with irreversible pulpitis that were subjected to emergency pulpotomies with 6 groups found that cotton pellet with eugenol, cressetin, isotonic saline, camphorated phenol, dry pellet or no pellet, found 96% of the patients reported sufficient pain relief after treatment with an emergency pulpotomy. So in this case, use of different sedative dressings had no pain relieving effect. Treatment strategies for vital teeth. With no swelling, complete debridement, it's unlikely to have a true flare-up. If there's pain after, reassuring the patient and prescribe a mild to moderate analgesic. With a vital case with no swelling and incomplete debridement, it is possible that tissue remnants remain and they are inflamed. Repeat the working length, recheck, irrigate with copious sodium hypochlorite, and place calcium hydroxide as a temporary interim medication. Mild to moderate analgesics can be prescribed. The goal of instrumentation during emergency endodontic treatment is to remove infected tissues, give irrigants access to apical canal space, create space for medicaments and obturation materials, and retain the integrity of the tooth structure. For treatment of symptomatic apical periodontitis, Tronstad found in 2003 an access cavity and irrigation of the pulp chamber plus placement of eugenol in the pulp chamber would relieve pain in about 70% of patients in one day. Holstein found in 2002 that chemomechanical instrumentation only results in pain decrease of 50% of patients within one day and 90% within 2 days. Treatment strategies. How to determine what size to instrument to. Grossman and Oliet found debriding with a barbed broach loosely so that it could be rotated in the canal without binding, following instrumentation with at least a number 25 file. Natkin, in 1974, recommended, if there are time constraints, that the dentist would likely use the minimum degree of treatment to eliminate pain in fine canals, for example, instrumentation of mesial canals of a mandibular molar to a size number 20 file. Further studies on what size to instrument during emergency treatment, Torbenishad found in 1991 a pulpectomy in necrotic pulps and instrumenting at least to a size 20 or 25 file usually relieves pain. Antrim found the recommendation for irreversible pulpitis or necrotic teeth is to instrument straight canals at least to a size 25 and a 15 or 20 file in curved ones to remove as much pulp as feasible. Treatment strategies such as reducing occlusion have varying opinions here. That Creech and Justice in 1984 did not find prophylactic removal of occlusal contacts to be a pain preventive measure. In 1998, Rosenberg stated that occlusal reduction should aid in the reduction of post-instrumentation pain in patients whose teeth exhibit preoperative pain, pulp vitality, percussion sensitivity, and/or the absence of a periradicular radiolucency, with the presence of all four conditions being the strongest indicator. Treatment strategies for non-vital teeth. Necrotic with no swelling. The abscess is confined to bone and generally very painful. Establish drainage if all possible. Clean, instrument, and irrigate with sodium hypochlorite. The canals are dried and calcium hydroxide is placed. Do not leave the tooth open. A long-acting anesthetic and a strong analgesic are recommended. Incision and drainage may be performed when there is presence of a collection of pus which points from a fluctuant abscess in the soft tissue. This decreases the number of bacteria. It decompresses the periapical pressure and provides pain relief. It prevents the spread of infection and accelerates healing. In the case of non-vital tooth, treatment strategies for a necrotic tooth with swelling are incision and drainage, debride canals, dry canals, place calcium hydroxide, strong analgesics, antibiotic administration if the infection is rapidly spreading and there's diffuse swelling. If localized, no antibiotics. In the cases where incision and drainage is performed, local anesthetic is applied best by nerve block. This is to avoid injection into swollen tissues and spreading infection. For the incision, know the anatomy. A vertical penetration of the periosteum with a sharp blade. A drain may be placed, but only in cases with moderate to severe cellulitis and an aggressive infection, and they may not be necessary. Placement of a drain involves the following. anesthetize, incision, placing the drain with cotton pliers, and a suture to retain the drain. There has been a change in the practice of trephination from 1977, when Dorn found 15.9% of clinicians would perform a trephination with a necrotic pulp and diffuse swelling and no drainage through the canal, versus Gatewood in 1990 found only 8.3% of clinicians would perform trephination. Cortical trephination is perforation of the cortical bony plate to accomplish release of pressure from the accumulation of exudate within the alveolar bone. This is illustration showing a burr to trephinate. Comparing pulpectomy alone versus pulpectomy with trephination, Moose in 1996 compared pulpectomy alone versus pulpectomy with trephination in 17 patients with preoperative pain, 11 of which received a pulpectomy alone and 6 received pulpectomy and trephination. The trephination group reported significantly more pain intensity and unpleasantness at 4 hours. Trephination effects on pain have been studied by NIST in 2001 with 50 patients with necrotic pain and periapical radiolucency evaluating post-op pain and swelling after trephination found no significant reduction of pain or swelling. Chesner found pain relief with cortical trephination and also showed prophylactic trephination reduced post-op pain by 16 to 25%. Trephination as a procedure today is less commonly used. In 1977, Dorn, Mudnick, and Feldman found that a survey of diplomats indicated 16% would perform trephination on necrotic teeth with diffuse swelling and no drainage through the canal. However, by 1990, Gatewood and Hemel found only 8.3 would perform this same treatment. Leaving the tooth open as a technique should only be done in rare cases when there is no satisfactory alternative. The exudate is so severe that it's virtually impossible to close the tooth. It's preferable for the patient instead to return for further treatment in 24 to 48 hours. A study by Wine in 1975 found 225 vital teeth, 81 left open, 144 closed, found statistically significant higher incidence of exacerbation among teeth left open after emergency treatment. Statistically, a larger number of appointments were required when the teeth were left open. When leaving the tooth open was studied, Tyler-Hain in 1995 studied 601 non-vital teeth with 103 left open for drainage, 197 closed with intracanal medicaments, and there were 404 non-emergency teeth treated used as a control. There were no differences found between the groups, but the higher the number of bacteria detected with Gram staining was higher in the teeth that were left open. Leaving the tooth open. In 2011, Gutman and Lovedahl found in no cases should a tooth with an inflamed vital pulp or with a symptomatic apical periodontitis without swelling be left open for drainage. Wine said vital teeth should not be left open. Torres said leaving canals open to the oral cavity may result in formation of apical cysts. Why we shouldn't leave the tooth opened. Many studies have found that the longer a tooth is left open for drainage, the more often apical surgery is required. A study by Bentz of 5,000 teeth with 10.4% left open, 18% required apical surgery to manage periapical inflammation. The higher the incidence of flare-ups when closing the tooth for the first time, the more postoperative appointments are required to manage the closure of the tooth, and the higher the number of intracanal bacteria. The residual effect of preoperative pain. Genet and Wesselink in 1987 found a non-vital tooth in preoperative pain on the day of treatment caused about 4 times the incidence of postoperative pain as teeth with an asymptomatic non-vital pulp and twice as often as teeth with a vital pulp with or without preoperative pain. Similar results were found by Harrison in 1983, Seltzer 1961, and O'Keefe in 1976. The residual effect of preoperative pain. Segal in 1984 found that 89% of emergency patients had been in pain for longer than 1 week. 40% of these patients reported that they could not sleep. The effects of preoperative swelling. Glennon and Walton found that preoperative swelling was a predictor of postoperative pain and flare-ups. Factors to consider in the planning of your treatment with emergency endodontic procedures. You can influence whether there's 1 or 2 visit treatment, intracanal medicaments, the risk of overfilling, prophylactic therapeutics such as antibiotic and pain medication, patency of the tooth, and drainage of infection. 1 or 2 visits for treatment. Literature generally shows no significant difference in pain or flare-ups between 1 or multiple visits for endodontic treatment. Some studies even show a higher incidence of pain with multiple visits. There's increased chance of contamination and leakage with multiple visits. Studies comparing 1 versus 2 visits for endodontic treatment have been done. Retrospective studies. Sultanoff in 1978 had 88 cases treated in a single visit versus 193 in multiple visits. There was significantly more postoperative pain after the single visit. Eleazar in 1998 found 16 flare-ups, that was 8% in the 2-visit group versus 6 flare-ups, 3% for the 1-visit group. Concluded little or no difference between single and multiple visit endodontic therapy. Further studies comparing 1 versus 2 visits for endodontic therapy. A prospective study, Dorenzo in 2002, had 39 patients root canal in 1 appointment and 33 root canal in 2 appointments. These were vital teeth, non-vital, and randomly assigned. He found no significant difference in postoperative pain. Oliet in 1963 had 264 teeth in a single visit versus 123 in 2 visits and found no significant difference in patients who exhibited moderate to severe pain in 1 or 2 visit treatment. There have been a very large number of intracanal medicaments studied and used in root canal therapy. Medications studied for intracanal medicaments include Maddox 1977, Formocresol, CMCP, Eugenol, Crescidin, and iodine potassium iodide, and a dry cotton pellet. Harrison and others in 1979, 1981, and 1983 studied camphorated perchlorophenol, Formocresol, or sterile water. Trope in 1990 studied Formocresol, Lettermix, and calcium hydroxide. Walton in 2003 studied calcium hydroxide versus only a cotton pellet in the chamber. Overall, intracanal medicaments do not significantly reduce post-treatment pain or flare-ups. Corticosteroids have been used and studied as an effort to reduce pain postoperatively. Corticosteroids have been studied for the prevention of post-operative pain by Jalalzada in JOE 2010 and found significantly less postoperative pain with prednisolone 30 milligrams administered 30 minutes before root canal treatment. Pochapsky, Oral Surgery, 2009, compared placebo-controlled study of with pre-treatment 4 milligram dexamethasone, significantly less post-endodontic pain after 4 hours and after 12 hours after treatment. Corticosteroids have been studied by Marshall 1993, Glassman 1989, Mersvarsvar 2008, Liesinger 1993, found pre-treatment with oral corticoids is effective in reducing post-endodontic pain for at least 12 hours. The oral administration of 30 milligrams prednisolone or 0.75 4 milligram dexamethasone 30 to 60 minutes before treatment. There are side effects to consider with corticosteroids. Yagila and Needle in 1998 found doses of hydrocortisone greater than 20 to 30 milligrams given daily for more than a week can cause effects simulating Cushing's syndrome. Trowbridge and Emling in 1997 found that corticosteroids can inhibit healing at high doses, so these are serious to consider. There are concerns with prophylactic antibiotics as the resistance of bacteria to antibiotics and the possibility of Clostridium difficile superinfections. Prophylactic antibiotics are not found to be effective. Pain is not an indication for antibiotic treatment. Antibiotics are only indicated when the patient is febrile and for patients who present with cellulitis. Antibiotics are indicated if there's a diffuse spreading of infection or evidence of systemic involvement, feeling of malaise, or elevated body temperature. Prophylactic antibiotics are not found to be effective. Longman and others in 2000 found that antibiotics are not efficacious in preventing post-treatment symptoms of pain or swelling or flare-ups. Nagel and others in 2000 found that antibiotics are ineffective for pain relief in the case of irreversible pulpitis. There's a difference between inflammation and infection. Prophylactic antibiotics are not effective was found by Fawad in 1996, Henry 2001, Torbenejad 1994, that antibiotics are ineffective for pain relief in the case of symptomatic apical periodontitis. Abbott in 1990, Martin in 1997 found pre-treatment with antibiotics is not beneficial and seems to have no therapeutic effect. Antibiotics are not an alternative to dental intervention. They are an adjunct to it. Prophylactic antibiotics were found by Walton with 80 patients given 2 grams of penicillin before appointment and 1 gram after, no effect. Pickenpaugh and Reeder in 2001 found a prophylactic dose of 3 grams of amoxicillin before endodontic treatment with asymptomatic teeth. There was no beneficial effect. Research by Morse did find prophylactic antibiotics helpful in 1987 with 315 patients, necrotic teeth with periapical lesions. When Group 1 did not use antibiotics immediately, flare-up was 19.6%. In Group 2, antibiotics were taken at the first sign of swelling, and the patient controlled this. Incidence was 4.3. In Group 3, antibiotic use was mandatory pre-treatment, and the incidence was 1.5. Inter-appointment flare-ups. The definition of flare-up by the American Association of Endodontists is an acute exacerbation of an asymptomatic pulpal and/or periradicular pathosis after initiation or continuation of root canal treatment. A flare-up is described as the occurrence of pain, swelling, or combination of these during the course of root canal therapy, which results in unscheduled visits by patients. The incidence and predicting factors for endodontic treatment flare-ups are host factors and dentist-controlled factors. Some of the host factors are the preoperative condition, such as a severe painful episode, gender, age, tooth type, patient receiving medication, and psychological factors. Dentist-controlled factors are over-instrumentation, inadequate debridement, debris extrusion, and single versus multiple visits for treatment. Preoperative pain. This is the only consistent factor that predicts post-endodontic pain. There are significantly more flare-ups in teeth presenting with pain or swelling of periradicular origin. Janae Wesselink in 1987 found that preoperative pain and non-vital teeth were 4 times more likely than asymptomatic to have post-endodontic pain. Age, studied as a factor in endodontic flare-ups, is found to be non-significant. Studies have shown patients ages 40 to 59 having most flare-ups and under age 20 as least flare-ups. Taking a look at gender on the relationship to endodontic flare-ups, Walton and Fouad in 1992 found 4.3% female versus 2.2% with males, so slightly greater incidence of flare-ups with female patients. Torbinachad and Kettering in 1988 found that women over age 40 had more flare-ups, with a percentage of 64.3% female to 35.7% male. Pulpal and periapical diagnosis does affect the chance of a flare-up. The percentage of flare-ups is higher in non-vital teeth. Walton in 1992 found 6.5% non-vital versus 1.3% of flare-ups in vital teeth. Moore and Rothstein in 1992 also found 2-to-1 ratio, and Barnett, 1989, 3% flare-ups in necrotic teeth compared to 0.2% in vital teeth. When presence of a sinus tract was studied, Walton and Fouad in 1992, Torbinachad and Kettering in 1988, the presence of a sinus tract was never associated with flare-ups. There were no acute exacerbations observed among teeth with sinus tracts. The presence of a periapical lesion has been found to contribute or have no relationship with a higher incidence of flare-ups. Large radiographic lesions, a higher incidence of flare-ups was found by Walton in 2002 and Morris in 1997. A significant more flare-ups was found in teeth with periapical radiolucencies by Imura and Zualo in 1995. No radiographic lesions was found with a higher incidence of flare-ups by Fox in 1970 and Frank in 1968. Symptomatic teeth without radiolucent areas were more susceptible to flare-ups was found by Seguera in 2002 and Torbinachad in 1988. Retreatments have been associated with a higher incidence of flare-ups. Torbinachad in 1988, Morse 1986, and Seguera in 2004. Wolfson and Seltzer in 1975 found the use of solvent in retreatment may contribute to flare-ups. Amiro and Zualo found that retreatment cases are more difficult to treat and that there is a tendency to push fragments of gutta percha and other contents to the periapical tissues. Tooth position is a factor in the likelihood of endodontic flare-ups. Trephination, Cuttering, and McGraw in 1988 found more flare-ups were observed in the mandible versus the maxilla, theorized that mandible has a thicker cortical plate than the upper jaw, and this may cause the accumulation of exudate, which causes more pressure compared with the maxilla. Most problematic teeth are mandibular molars, then maxillary molars, mandibular premolars, and maxillary lateral incisors. Microbial factors in endodontic flare-ups. Segura and Barnett in 2004 found microbial influence is arguably the major and most common cause of inter-appointment pain. Sundquist in 1976 identified microbial flora of 32 single-rooted teeth with necrotic pulps. Most were obligate anaerobe rods. In all teeth with painful symptoms, Bacteroides melanogenicus was present in combination with other organisms. In the 25 teeth without symptoms, none contained Bacteroides melanogenicus. Microbial factors were studied by Chavez de Paz in 2002. Of 28 patients who sought emergency treatment after initiation of root canal therapy, the flora was polymicrobial. The dominant bacteria were gram-negative anaerobic. Microbial factors were studied further by Griffey, Patterson, and Miller in 1980. Pain and foul odor were significantly associated with the presence of Bacteroides melanogenicus. Shine and Schilder in 1975 found more endotoxins in the periapical areas of painful teeth than in those of asymptomatic teeth. Psychological factors were studied by Scott and Hirschman in 1982 and found they influenced the patient's pain perception and reaction thresholds. Anxiety intensifies and may perpetuate painful episodes. A dentist-related factor of postoperative pain includes overinstrumentation. Sakura in 2003 determined that apical extrusion of infected debris can disrupt the balance in asymptomatic cases. He proposed that asymptomatic periapical lesions associated with infected teeth have a balance between the microbial aggression and the host. If extrusion of microorganisms occur into periapical tissues, the host will face a situation now challenged by a larger number of irritants. The sequel over instrumentation may create two conditions requiring emergency treatment during the course of a root canal therapy: the phoenix abscess and acute periapical periodontitis. Acute apical periodontitis may arise as a result of overinstrumentation and extrusion of the canal contents through the apex, leaving the tooth in traumatic occlusion, placing too much medicament in the pulp chamber as an inter-appointment dressing. Management of acute apical periodontitis. Irrigation with sodium hypochlorite. Careful drying with paper points is usually sufficient to alleviate the symptoms. The occlusion must be checked, as there is likely to be a certain amount of extrusion of the tooth from its socket. The phoenix abscess. This is a sudden exacerbation of a previously symptomless periradicular lesion. Alteration of the internal environment of the root canal space during instrumentation activates the bacterial flora. Occurs after initial instrumentation of a tooth with a pre-existing chronic periapical lesion. Management of the phoenix abscess, irrigation, debridement, and establishing drainage. In severe cases, it may be necessary to prescribe an antibiotic. Dentist-related factors. Inadequate debridement. Sundquist, in 1992, said leaving microbes behind can cause overgrowth of strains. When sufficient numbers are reached, the damage is intensified and lesion exacerbates. Segura and others in 2002 said disrupting the equilibrium of the endodontic microbiota, such as missed canals and the presence of isthmuses. Although post-obturation pain exact etiology is unknown, there are factors that can be involved, such as the immunologic response, infection, physical tissue damage, a high restoration, overfilling, underfilling, root fracture, or a combination thereof. Factors affecting post-obturation pain. Harrison and Baumgartner, 1983, found those with inter-appointment pain have a higher incidence and degree of post-obturation pain than patients who experience no inter-appointment pain. Maddox and Walton, 1977, fewer instances of post-op pain after obturation versus appointments in which pulpotomy or instrumentation were performed. Factors affecting post-obturation pain. Harrison and Baumgartner in 1983 found those patients with inter-appointment pain have a higher incidence and degree of post-obturation pain than those who experienced no inter-appointment pain. Maddox and Walton in 1977 found fewer instances of post-op pain after obturation versus appointments in which pulpotomy or instrumentation were performed. Post-treatment antibiotics are recommended when swelling goes beyond the local area, that is, cellulitis, or fever, trismus, lymphadenopathy, or malaise. In the situations just mentioned where post-treatment antibiotics are indicated, the antimicrobial treatment of first choice is penicillin with amoxicillin in particular. Alternatives are now azithromycin and formerly clindamycin and metronidazole. Analgesics are adjunct to causal treatment approaches. Causal endodontic treatment causes more than 50% pain reduction by 1 day and about 90% by 2 days. The first strategy is to prescribe the right non-narcotic analgesics, either an NSAID or acetaminophen for a patient who can't take an NSAID. The flexible analgesic strategy has been recommended to get a better result in pain relief than either one alone, and minimizing the dose of opiates. The dosing level of 800 milligrams ibuprofen is highly effective in relieving pain. The combination of ibuprofen plus acetaminophen to those with ibuprofen alone or placebo is greatly enhanced. Analgesic was studied by Nustang in 2003. to 323 patients with irreversible pulpitis or necrotic pulps, compared narcotic, non-narcotic, or antibiotic. Patients with necrotic pulps reported more pain relief than patients with irreversible pulpitis, but there were no difference found between the two groups regarding the type of medication. Non-narcotics without concomitant use of antibiotics were less successful in controlling pain with the group with irreversible pulpitis than the necrotic teeth. The study of analgesic by Rogers and Johnson in 1999 found with 48 patients, 4 groups, oral ibuprofen, oral placebo, intracanal dexamethasone, and intracanal ketorolac tromethamine, or Torazol, found that ketorolac tromethamine or dexamethasone provided statistically significant pain relief at 12 hours. Compared with the placebo, there was no significant difference between ibuprofen and the placebo. Therefore, the same reduction in pain could be achieved through the use of oral ibuprofen. Nenhenick in 2004 studied the combination of ibuprofen and acetaminophen with 57 patients. Local anesthesia, pulpectomy, post-op analgesic with 600 milligrams ibuprofen versus 600 milligrams ibuprofen and 1,000 milligrams acetaminophen. The result: combination of ibuprofen and acetaminophen was more effective than ibuprofen alone for the management of postoperative endodontic pain. Conclusion: before any dental treatment is provided, it is essential that the patient's symptoms have been correctly diagnosed. Conditions causing dental pain on the first presentation may include pulpitis, reversible or irreversible, periapical, periodontitis, dental abscess, as well as cracked tooth syndrome and other orofacial pain disorders. Conditions arising during treatment may include high restorations, very common, root or crown fractures, problems with root canal instrumentation, and infection. Pain following treatment may be due to any of the above or failure of the root canal treatment. Using analgesics and antibiotics require a sound rationale for which the patient clearly benefits. However, patients should always be cautioned to expect a certain amount of post-treatment discomfort, particularly when they had a lot of pre-treatment discomfort or a retreatment.